This episode of Common Health is brought to you by Reg Lantern. Reg Lantern is a straightforward and easily understandable software platform built to assist community health centers in staying compliant so they can focus on serving their patients rather than paperwork. For health centers that are serious about achieving, managing, and maintaining compliance, Reg Lantern provides a comprehensive approach and is an affordable and valuable solution. Reg Lantern can help your health center. Contact them today at reglantern.com. That's REG, as in regulations, lantern.com. For special discounts, mention that you heard about Reg Lantern on the Common Health podcast.
Hey there, and welcome to Common Health from the Virginia Community Healthcare Association, or VCHA, or what we're also known as is VCHA. I'm Tracy Douglas-Wheeler, VCHA's Chief Executive Officer. On Common Health, we're here amplifying the voices of community health, both those who give care and those who need it. We are quite excited today. We have a very special show for you. This was a show that we were really looking forward to, and we've got two guests here. Those two guests come from a very special organization that's located in Richmond, Virginia. And these particular people that we have here today bring a special gift in what they do, and the place that they work is certainly what we would call, and many would call, probably a blessing to this particular community. The title of our show is actually called News from the Daily Planet, and not Superman's newspaper. And the reason why we've titled this show that is because the name of the organization, which is a community health center that services multiple individuals that feeds into the Richmond, Virginia community, is called Daily Planet. It is the Daily Planet Community Health Center. It has been around. It is an icon for the Richmond community. And these two individuals that are joining us today are the CEO, that's Anita Bennett, and the Chief Medical Officer, who is Dr. Patricia Cook. So with that, ladies, welcome, and thank you for joining us. So we got to go right into the name of this organization, right? Daily Planet. Talk to us a little bit about how we got that name, how long it's been around, right? And what is its history?
Sure. We get this question a lot, especially if you're a fan of Superman. But the origins of the Daily Planet actually began in 1969 when a woman by the name of Ann Lane, who happened to be a professor of social work at VCU, noticed that there were an increasing number of homeless individuals in the Richmond community. So she gathered herself and a group of students to go out and began as outreach services to those individuals in the Richmond area. They began to provide food, shelter, clothing, and their mission grew. And as it grew, they decided they needed a name. So Anne, a very wise woman, went and spoke directly to the clients and her volunteers and said, what should we call this? What should we do? And both the volunteers and the clients that they served related their feeling back to being like Clark Kent, stepping into a phone booth and transforming themselves into Superman. So it was at that time that group of individuals, both clients and staff, decided to name the organization the Daily Planet, paying homage to the newspaper that Clark Kent worked for.
Has there been any conversation to change that name because you all have evolved over time, or are we just going to stick with the lineage of the organization?
Well, we did evaluate it as most recently, 2016. We evaluated the name. We did a full community survey. We reached out to community partners. We reached out to our clients, our staff. And what we found is there was a deep love for the Daily Planet. A lot of our health systems, our providers, we've been around for 53 years. We are a part of the community. And there are a lot of very positive feelings about the Daily Planet. But we also wanted to reinforce that we have evolved. We are not just outreach services anymore, that we are truly a comprehensive health service program. So we formally changed our name to Daily Planet Health Services.
So when you all first started out, was it just medical services that you were providing, or were there some other things that you were doing outside of just medical services when they first started out?
Over time, we did increase our services. In 1987, prior to 1987, we were predominantly outreach services and primary care. It was at that time that, as a nation, we passed an act, the Stewart-McKinney Homeless Assistance Act, that allowed us to receive federal funding. And that federal funding is specifically geared toward helping the homeless and providing health care. Under the umbrella of health care, we can now offer behavioral health as well as dental care. So today, we are a full service healthcare service program. We offer primary care, behavioral health, dental care, case management, and outreach.
What does outreach mean? Because, we've got many listeners here. And so tell us what outreach means.
So I've been at Daily Planet as a primary care physician and as the chief medical officer for the past 2 years. And I think the best way to tell you what outreach means is my first session in clinic. This was a new setting to me. I had not been in a healthcare for the homeless clinic before. And an outreach worker brought a person from a tent to their appointment. And that's when I knew I was someplace different. I had never worked with outreach workers. Our outreach workers go out into places, encampments, single shelter areas where people have created shelter along the river, or where people have created shelter behind a building or in a storage unit, wherever they have created shelter for themselves. Our outreach workers go and get them, and they do outreach. They reach out to them. Sometimes it's in the form of a physical thing, like, hey, do you need a toothbrush? Hey, can I get you some food? Can I get you some bottled water? Things to keep you safe. And then they build that relationship and that trust, because oftentimes those people don't have a lot of trust in the systems around them. So the outreach workers literally go out, build trust with the client, and then bring them into the building, where then they can get more comprehensive case management. They can get medical care. This gentleman that I saw that day was a man who last had interacted with medical care more than 10 years ago, had been living outside for more than 8 years. And his last interaction was when he'd had a heart attack and went to the hospital.
Wow.
So from that time forward, for the next 10 years, he never saw a physician. He was not on any of the medicines that you would think somebody should be on after their heart attack. And through the relationship he built with our outreach worker, he came in, and he's continued to come in.
Wow. So you speak to Daily Planet Health Center, Community Health Center, focuses on homeless individuals. So how are you different from the other FQHCs? Because we've had other FQHCs on our program, other individuals from those health centers. And I'm curious, what's the difference between your organization and the organizations that we've had on in the past?
For a lot of FQHCs, their target population is anyone who is under 200% of federal poverty level and below, or anyone who is generally uninsured or underserved. The Daily Planet falls under two categories. We fall under the Healthcare for the Homeless program, or grantee, and we are also a primary care for public housing grantee, which means our primary focus, or our targeted efforts, are spent mostly in those two populations. So we look for homeless individuals or individuals with housing instability, and our second would be public housing and individuals living in and around public housing.
It's interesting also that you talk about that, because we had an individual on the show that advocates on behalf of the community health centers in the state of Virginia. One of the things that he talked about was how health centers offer their services based off of sometimes sliding fee scale. Is that something that you all do as well?
Yes, absolutely. So everyone that comes to our program will receive an income verification, and we will look to see where they fit on our slide. So we will evaluate their income and the number of individuals in their household to see what they qualify. If you do have someone who is truly homeless, No one will be turned away from our program ever if they're unable to pay. We will absolutely take them and provide care to them. But we always work to make healthcare affordable through our slide.
So by being healthcare for the homeless, that adds a little extra twist to that, because the majority of our homeless patients who are living as an unsheltered homeless person, oftentimes they don't have identification. They don't have driver's license. They don't have copies of their insurance cards. They certainly don't have income verification because they don't have a mailing address. They don't have, they're most often unemployed. So that also is where outreach and case management comes into play, right? To verify someone's status as being homeless takes the place of needing to do that income verification. So that automatically makes them eligible for our sliding scale.
Could someone like me go to your and receive medical services? I'm not homeless. I'm a professional. I have health insurance. If I wanted to come to your organization to get my medical services, am I able to do that?
We do see some individuals who do not meet the homeless or public housing criteria, but it is definitely a much smaller portion of individuals out of our patient population.
Now, let's speak to the quality of care component of that, though, because I can, as the chief medical officer, I'm going to say this with pride, I can guarantee you that our homeless individuals are getting the same quality of care that you would want from your primary care physician. We're after the same things. We have to get a little more creative in how we get them done. You know, it's really hard for someone living in a tent to do a prep for a colonoscopy. It's really difficult to get people to mammogram orders when the main thing that is on your mind, if you're living outside or you're bouncing from emergency shelter to emergency shelter, you're not going to make an appointment for next Tuesday and show up for it because you're too busy finding your next meal and your spot to stay. So we recognize that as a social determinant of health that impacts your traditional health problems, like your diabetes. Mm-hmm. If you're unsheltered, you're not going to have a way to refrigerate your insulin. It's going to become very difficult for you to carry a month's worth of medicine. So we try to engineer workflows that can help people through that piece and get them to a more stable spot where then they can take care of their chronic medical conditions or their cancer preventive screening type.
So how are folks ending up homeless? Because I know many of us think that it won't happen to us. How do some of us end up in the conditions of being homeless?
Domestic violence. Domestic violence definitely makes a portion of our population become homeless. I've had people that are employed and actually their health care bills make them homeless, right? So I had a patient once who was an employee of a hospital system, had a sudden medical crisis that landed her in the hospital for several weeks, and during that time lost her apartment because she wasn't out to pay rent. So suddenly she was in a shelter, and when she came to us the first night, she said, I've just never been in this situation. I can't sleep. I've never been in a shelter. So it can happen in the blink of an eye with one small thing. You know, I had another guy who was in a moped accident. His moped was his way to get to his job. When the moped got destroyed, there was no way for him to get to his job. There was no way for him to pay rent. He was evicted. So right now we're in a little bit of a honeymoon with the eviction moratorium, and we're losing that now. And we're going to see so many, I think, we have seen through the pandemic, the financial strains of people losing their jobs. But we've had a little honeymoon with evictions. And now we're starting to see those pick back up again and people just landing on the street.
So what do you worry about as a provider with that happening, that more folks may end up on the street? What do you worry about with that?
I worry about, I can't help but worry about the children and the old people. And I feel like I worry about all of them. Yeah. But, during the pandemic, we started doing, even more outreach. We started taking medical, like for instance, when we had the vaccines, we started going to shelters and offering the vaccines, to long-term care or long-term stay hotels, which is where a lot of people land when they're on the verge of homelessness, right? They go to an extended stay hotel and pay for a week. So we started going to those hotels and doing vaccine events there. And when we did that, that was eye-opening because we found people who would have never found us. They were too new and fresh to the system. They had just landed in an extended stay hotel and didn't know how to access any services. And one of the families that we found during that was a family that had a four-week-old that had come from out of town, had given birth, left town, and ended up in this hotel, this extended stay hotel with a 4-week-old child, and no follow-up for that baby, no plan for follow-up for that baby. So I worry about that person. I worry about people that are amputees and in wheelchairs that can't even access the extended stay hotel, or people that are aging. And we know in this country we have a gap in taking care of people who are aging in all segments of society. But when you think about somebody who's aging as a homeless person, they don't have a family member to advocate for them. They don't have somebody who's saying, hey, Dad, you're not doing as well on your own. We should probably talk about how we can get you assistance. That doesn't happen.
I think I'm going to use the phrase hidden homeless. And I think in general, when people think of homeless, they think of someone standing on a corner with someone with a cardboard sign, right?
Yes.
That's what pops into our mind.
Yes.
And usually with that comes some other thoughts of how that individual ended up there. What life decisions did that individual make? And we begin to make judgments. But there is a large group of individuals that I would call the hidden homeless that Dr. Cook is just speaking about, are those families, are the working homeless, are the children that you don't see on the street corner, but you find them sleeping in their cars. And they're there because they are embarrassed. They are there if you ask them if they're homeless, they're going to tell you no.
Right.
Because there is a stigma associated with being homeless.
Yes.
So for me, I worry about the growing number of homeless children. So in the United States, the number one growing population of homeless is unaccompanied minors. In the state of Virginia, the number one growing population is seniors. So just as Dr. Cook spoke about, those individuals, it's a very prideful thing to admit that you can no longer take care of yourself. Even if you, as a homeless person, have been taking care of yourself on the street,
right,
at some point you reach a point where you are not able to be on the street anymore. And that is that gap of where do they go?
I know you all provide behavioral health services. There's also this stigma that a lot of homeless folks are the schizophrenic, and that, they just have a lot of mental health issues. Is that really what we're seeing in your clinics? Are you seeing, or is it all over?
It's a little bit all over, but there are definitely, I think it's not all homeless people have mental health problems, right, but many people who have serious mental illness end up homeless.
Yes.
Right? Corollaries.
Yeah. What can we do to make a difference with our homeless population?
It's going to take a lot of stakeholders getting involved to make a difference with our homeless population. Effort. So we have, what we call the continuum of care around the greater Richmond area that involves people trying to do diversion, people trying to do rent relief, so that if you call that number within 24 hours of losing your home or within 3 days of losing your home, can we keep you there a little bit longer? Can we help you reestablish a connection with somebody else to prevent you from hitting the street? Then we have our emergency shelter providers and our longer term shelter providers. But I'll tell you where it all bottlenecks in our city is getting out of shelter into an affordable housing. And we're seeing more and more people that are being evicted not because they've missed a rent payment, but because their landlord has decided to sell and redevelop their housing. And you can't the average housing cost in Richmond, the last time I think we checked, the fair market rent value was around $1,200. And if you are living on a disability check that gives you $760 a month, finding even a room for rent for less than $350 is difficult. So having an affordable housing option is the thing, I think, that all of it has to work together, but that has to loosen up for everything else to be able to work, because you can only stay in a shelter so long before you're ready for that next step. And if you are making minimum wage, if you're making even a living wage, it's very difficult to pass the credit checks. Landlords are looking for a credit score of 700 and a certain income value. And it's just really difficult in our city right now to find an affordable place to live.
I think the reason I was paused by your question was it's a massive question, right? When I step back and look at that question, I see it as so broad because we're tackling the cycle of poverty, right? What are the steps that we can take as individuals to stop that cycle of poverty? So when we look at the changes that have taken place in Richmond over a period of time, we see that new business development has come in. We have a world-renowned medical academic campus sitting in our city. We have arts, we have theater, we have a lot of amazing things. But a lot of things have happened in the outskirts of the city. In terms of the counties surrounding Richmond have had population explosions, right? They see the benefit of what is going on in our city. But the city itself, population has remained flat, if not declined in some years. And that is because when you look at Richmond City as a whole, there are areas of the city that the poverty rate as a nation is around 13%. As a city as a whole, we're at 23%. But there are pockets of poverty in Richmond that exceed 60%. So when we look at that level of poverty and you try to tackle homelessness, it is part of the cycle. Individuals who routinely follow that path and are in and out of public housing, homelessness, sometimes for some individuals it involves incarceration. There are lots of factors that feed into this cycle. And to Dr. Cook's point, it's a huge collaborative effort, but we have to realize the root of this is that you need to attack poverty and what people are experiencing day to day.
So how do you, given some of the complexities of the challenges around homelessness, how do you, as healthcare providers, convince the homeless that they need to pay attention to their healthcare?
So I think that's the hardest part of being a provider at Daily Planet. Whether you're a behavioral health provider, a dental provider, a medical provider. I heard somebody else say this, it's really hard just to sit with a patient who is so frustrated with their lack of ability to find shelter that they can't even begin to tackle their ongoing behavioral health problem or their ongoing medical problem. And you have to meet them where they're at and be content to sit in that really horrible spot with them. I can prescribe all kinds of medicines, but knowing that they're not going to be able to get them, or I can give, hey, you should check your blood sugar 3 times a day, and we should really be careful about what you're eating. But when you're living on donations from a food bank, you can't do that. Mm-hmm. You don't have control over your own diet. You can't make your own meals. You can't cook healthy foods in the extended stay hotel. Right. There are so many other things that they're up against. It's really hard to talk about fine-tuning either preventive health measures or chronic disease management. And so trying to figure out ways where you can start to say, the pain would be a little bit better if we can get this diabetes under control. Maybe we could try these couple steps and see if that makes you feel better and you're better able to tackle the hurdles that are in front of you.
You talk about providing dental services at your location. And just hearing the challenges, Dr. Cook, with getting your patients just to even focus on the medical care, why are you even looking at dental services? I mean, how do you even get them to say, let's go sit in a chair and let's get our teeth checked too?
Teeth hurt. Teeth hurt. If you have a rotten tooth, which more than 50% of our homeless patients have rotten teeth in different places, and they hurt. And that can be one thing that we can fix. You can take out that tooth and it stops hurting, and that starts to build that trust of, okay, what's our next step?
One of the things we had heard on one of our other shows is that it's been difficult. There's a huge, nationwide, we've heard that it's very challenging in recruiting doctors, providers, nurse practitioners to come in and wanting to work in a community health center. We spoke with a physician that works at a rural health center and talking about how do you get a young resident getting ready to come out of their program interested in coming to work out in Martinsville, Virginia, right? What is it going to take to get our young physician providers, nurse practitioners, PAs interested in wanting to work at a Daily Planet or a homeless community health center? What does it take?
It takes a desire from the provider first. Like, this is not work meant for, no work is meant for everybody, right? But there are certain people that feel called to this work. And then having an administrative structure in place that can support that calling and allow them to pay back their loans is really the key to it. So and for us, we're fortunate. We're right next to an academic medical center. We partner with that center and let students do rotations. We pull people in during their residency to say, hey, this is street medicine. This is the way we do it. We go out on the street with a bag over our shoulder and we can take care of somebody's foot wound. If that is, and still, I still have belief in my colleagues that is what motivates some of them to be able to alleviate some suffering. This is a place where you can do it. You're not going to win all the time, but you're going to win some of the time. And when you do, it feels really good to really be able to help somebody to move to that next step. And we have a really committed force on the medical team, the dental team, and the behavioral health team of people. We tell them from the beginning, this is what you're getting into. It's not for everybody. You have to be able to process that trauma. You have to be able to find support in each other. And we have to be able to financially make it possible for you to do this. And a big part of that is actually having the National Health Service core loan repayment as a possibility for people. Then we can retain and keep those people.
I look at you, Anita, and you're sitting on the administrative side of what you do. Why work at the Daily Planet? There are probably so many other places you could have gone, but you chose to be the CEO of a homeless community health center. Why?
When I first came to the Daily Planet, I came as a board member, and I was drawn to the Daily Planet for its mission and commitment to the homeless. I think, just like Dr. Cook says, there is a calling for everyone. This was my calling and still is and remains my calling. I think we all have personal experiences where we can relate to the job that we do. And what makes us better at it is to be able to put ourselves in that person's shoes. Throughout my lifetime, I have had some good times and bad times. Yeah. And I can more easily relate to the situations that would end in homelessness or would cause someone to be homeless. And I have a lot of respect for the staff that we have. It is truly a family. The culture there is unlike any organization I've been a part of, and I've been a part of large for-profit and not-for-profit systems that have many hospitals, ambulatory care facilities, and you don't feel the same level of commitment and dedication that you feel when you walk in the doors of the Daily Planet. I have to say, I think, to Dr. Cook's point, if someone has a calling for this and they walk in the Daily Planet doors, they're going to be moved to stay because they will be inspired by what they see.
What's the future for Daily Planet, and what's the future for community health centers that service predominantly homeless and public housing patients?
For the Daily Planet, our our mission is to continue to grow to serve the community. So as the community need grows, we will continue to work with our board of directors to meet that need. The longer we have been in this role, the longer I have been in this role, I think as a leadership team, we have seen some gaps in our community where we feel very confident that the Daily Planet can step in and fill some of those gaps. We are going to continue to work towards that. We're going to continue to look for funding to support those efforts, whether it's to support seniors who need to transition to a different housing format, or it's new mothers, or and Dr. Cook can probably speak to some of those situations as well when a new mother finds herself homeless, how difficult that can be. But we will continue to grow and look for areas within the city to expand, potentially even in our neighboring counties.
Dr. Cook, on the clinical side, what do you see the future for Daily Planet, and then what do you see the future for medical care to homeless and folks who are in public housing?
So I think the future for Daily Planet goes back to that idea of the hidden homeless that Anita was talking about. There are a lot of people that are just getting by, whether they're in the extended stay hotel or whether they're couch surfing with a friend or a family member. What we learned during the pandemic is those people are out there and they're not even, they don't have they're unaware of the supports that could be here to help them. There are oftentimes when I get a new patient who is a homeless patient, they say, I didn't know this place existed.
Yes.
I didn't know I could come here and get this done. And so doing what we need to do on an outreach front to get to those folks and to be able to bring them into care, and then upscaling whatever services we need to meet their needs. Right now, for instance, one of the groups of people that we've recently expanded to are the Afghani refugees that have come into Richmond in large numbers.
Yep.
They're homeless. They don't have a place to be. And so helping those folks through that transition has caused us to have to bring on new language resources and new abilities to take care of more and more children. We're seeing our number of children that we're seeing is increasing every year. So training our providers in that pediatric care, our nurses in those pediatric blood draws, all of that sort of boots on the ground stuff to be able to have us ready to meet people where they are. We've brought on a mobile unit in the past year, so we're doing more mobile outreach. And then we've brought on a street medicine team in a very limited fashion, but it's growing, so that we partner an outreach worker with a medical provider to go to the encampments and to go to the tents. And that is, I think, starting to reach people that weren't going to be able to get on the bus and get to us.
You know, I would be remiss if I didn't talk a little bit about the current times that we're in with regards to the pandemic. How did that impact the Daily Planet? But then also, how did that impact our homeless population?
It impacted the Daily Planet in that our team stepped up to the challenge of the pandemic. We threw open our doors to people in need all across the community. And we went out and saw people. Like I said, we saw where some people were that we weren't reaching before the pandemic. So it opened our eyes to that a little bit. As an organization, it opened our eyes to a population that we should be getting out to get to. As a society, the pandemic was the great leveler. It doesn't matter whether you're employed or unemployed. If you get COVID, you need to be isolated. If you get COVID before the vaccine back in 2020, you were going to feel really bad, and we didn't know whether or not you were going to live or die. And that was the same whether you were employed and insured or whether you were unemployed and uninsured. You were contagious no matter where you were. If you were the worker in the factory, you were just as contagious as the supervisor was. So it became in the best interest of the supervisor to help you be able to take time off safely before you came back and infected everybody on the line, right? So it opened our eyes to a lot of things, I think. What I hope it opened our eyes to is that inequity that's been there all along. Hopefully it opened our eyes to that, and how when we all work together to take care of each other, we all come out better, right? The factory keeps working if we can keep people healthy.
Right.
COVID was an extreme example of that, but it lives on in terms of, if your diabetes is not under control, you're not going to be the best on the factory line.
Right.
So how can we help prop you up?
I think the other thing, it did help communities, and I think nationwide, communities had to pull together. Communities were forced almost to, as I've heard said, the virtual table to have conversations. And so we've learned a lot in that space. We have been able to find more appropriately where we fit within homeless services within the Richmond area. We strongly know where our role is as healthcare for the homeless program, and how that also relates to our community partners and what we owe, and how we plan to work with those community partners to not only keep our partners safe, but their clients safe as well. So I think our relationships are stronger than they have ever been after COVID. And that was because we all came together to manage the unmanageable for a period of time. I see it continuing. I see our virtual space continuing, and there's communications continuing. Dr. Cook's team set up on a clinical side an amazing telehealth program. Outstanding. So at one point, 65% of our visits were done by telehealth. We're going to continue using telehealth as a platform to deliver care. Our patients, it works well for some of our patients, especially those patients who have struggles with transportation. So a positive would be that we're going to continue to provide high quality care in a new format.
That's interesting that you talk about telehealth. How do you do telehealth with the homeless population?
You set up what we call a connection point terminal in the shelter. So when this started happening in 2020, of course, congregate shelters where people are in bunk beds and all eating together and sharing communal bathrooms became hot spots. And the people who worked there were afraid, the people who ran those shelters were afraid, and the people living there were afraid. So we all came together to put in some safety mechanisms, and we started to see people before they ever got to shelter to make sure they didn't have COVID. Right. And under the guise of that, we also were able to find out, do you have diabetes? Do you have hypertension? Do you have other behavioral health problems that we can help? And so we started to implant ourselves in the shelters, virtually and in person. Some shelters we go to and have clinics at the shelter once a week. Other shelters, we have what we call a connection point terminal, which is essentially a Zoom chat room that a person can log on to, see their provider, and have a medical visit without having to get through getting on the bus to get to us.
Right.
Now, how it impacted homeless services, of course, it had a huge impact on homeless services in terms of literally you had to distance people within the shelter. So instead of every bunk being available, every other bunk became available, which shut the doors to some people that were living on the streets.
Yep.
It opened other doors because we came up, like many cities across the country, started non-congregate shelters where people were staying essentially in hotels, right?
Right.
And running shelters in hotel spaces.
Yes.
And we learned there are some advantages to that and there's some disadvantages to that, right? Operationally and for the people involved.
There's so much more that I would love to talk with you about, and I really hope that we can bring you back and have more conversation. Before we close out this show, I have one last question. You really have to be committed, like you all said, to doing what you do, and it's not easy. What do you do from an administrator perspective, Anita, and then Dr. Cook, from a clinical perspective? How do you keep yourself balanced? How do you address for yourself your well-being?
For me, I lean on my team. We have the best staff I have ever seen. We have an amazing group of people. I'm very, very blessed, and I know you used that word earlier about how the community is blessed to have the Daily Planet. I consider myself extraordinarily blessed as a person to be able to sit in this seat. It is a gift. It reminds me every day of my blessings. And the people that are there are blessings to our patients. And that helps to keep you grounded.
Right. And I think Anita said it very well, because it goes back to that Mr. Rogers thing, right? So in times of crisis, you look for the helpers.
Yeah.
I feel very blessed to be one of the helpers. And
it's interesting you refer to yourself as one of the helpers.
The other thing that I think that I hold on to a lot is there's a story of a kid walking along the ocean, and all these starfish have washed up in the tide.
Yeah.
And somebody says, well, you can't possibly put, the little boy's throwing them back in one at a time. You can't possibly get them all. You can't possibly get them all, but you can get the one that's in your hand.
Yeah.
And so on the nights or the days where it feels like it's been really long and you feel like you've missed an awful lot of starfish, or you've missed the ocean when you tried to throw them, I don't know.
Right.
You threw them the wrong way. I don't know.
Yep.
A warm bath and thinking back to the ones that you got into the ocean, where that's helpful.
Well, ladies, thank you. And thank you to all the listeners for tuning in to Common Health, brought to you by the Virginia Community Healthcare Association. If you enjoyed this episode and you'd like to help support Common Health, I encourage you to hit the subscribe button, share it with others on social media, leave a rating and review, or visit our website at www.vcha.org. This is Tracy Douglas-Wheeler. Thanks again, and I'll see you next time.